Hello, my dear doctors. My name is Dr. Heather, and currently I'm practicing in Victoria as a GP. I've gone through the fellowship recently, and I like to share some of my experience with those examinations. So, as on my channel, I have done the series of presentations when I was going through my MRCPI examination. So I'm going to talk a bit about the CCE part of the FRACGP, and this is the final part before you get your fellowship. So as we go along, my plan is to make some videos for you, and I hope these will be helpful for you. The CCE actually is the approach is totally different from what we have done in the AKT and KFP, because here is more of communication rather than your knowledge. And if you have a right approach, it will be quite easier and it will be stress-free. Important tips which I like to give you for the CCE is go through the scenario in 5 minutes, stay focused, and try to answer all the questions which are asked. The examiners usually they have a set of answers which they are looking for, and so that they can tick on their mark sheet. And it's all about the deciding factor for the pass and fail. It all depends whether you have answered all the questions. So let's start with our first case today. And as we go along these cases, I'm going to give you some tips that will help you to pass the exam. So let's talk about the clinical encounter today. So today I have selected this case. This scenario is quite common. It has come in previous examinations as well. So here it is a 55-year-old. It's a clinical CC clinical encounter. And remember, in the CC examination, there are two types of cases. We have clinical encounter and case discussions. So this is it's a 55-year-old male on long-term opioids and post-fracture. So when you go through any of these stations, you have 5 minutes where you'll be given all the information. Use these 5 minutes very wisely. Not only that you have to extract the important information from whatever the reading they have provided, but you have to plan that how you're going to do your consultation. So this is a case setup here. He's a 55-year-old man and he's presenting for medication review. And he has been on long-term opioids. So patient is on Palexia and Endone. They maybe just give you the dose and OxyContin as well. He had a fracture about 2 years ago. Obviously, it has healed now. And he reports intermittent pain and expresses concern that he may not cope without his opioids. So in this, then there will be obviously set of questions that take the history. If they say do the examination, obviously you have to do the examination. Ideally you not, but you have to mention that what examination you like to do. If they say that patient concerns should be addressed, then they should be addressed. So here we have to identify that the patient has a problem, is a chronic non-cancer pain, and we have to recognize there is a prolonged opioid use beyond expected healing and dependence risk. We need to flag that one. So as I told you, it's all about the communication, that how you communicate. So you can either, because we already have some idea about the patient and we know what agenda is, so you can start by the simple thing that whatever is the name here, like Mr. Robert, how are you feeling today? So is it okay that we talk about your medicines today? So we have to do the open-ended questions. So I've given you our example here. So I will start by, I can see you've been on strong pain medications for quite some time since your fracture. I like to understand how your pain is affecting you now, uh, how helpful the medicines really are, and then we can talk together about the safety way forward for your pain and well-being. Now, this is a pretty long statement actually, but you can break it down to the different. So, important thing is about your communications. You're going to just build a rapport the with the patient and start acknowledge that you have some information because you read through, and then make it a base, and then do your questions of following all the informations you have. So why this goes well when you do these types of communication? Because it's a non-judgmental, it's a collaborative, and avoid the things that you shouldn't be on these, because these becomes like confrontational, and always signal shared decision making, that we can talk together about this, the safest way forward, and or we can work together on this. Now, you'll ideally will take around 1 to 2 minutes for this, making the rapport, and these are the deciding factors. If you start well, sure, you'll build your confidence and you'll be doing well. Then we come to the detailed history for the, now you're going to, as you have built the rapport, then we come to the detailed history. So we're going to ask about the pain assessment. So we do the open focus questions: location of the pain, quality, severity, radiation, any neuropathic features like burning and tingling, triggers and reliever. Pain patterns are important, whether the pain is constant versus intermittent. On an average day, how bad is the pain out of 10? Pain scoring is always important to ask whenever there is a pain. And what does the pain stop you from doing? This is very important, that we should know how is it affecting the everyday activities of everyday living. Now, functional impact is a very high yield for CCE, and it is very important. Obviously, we're going to talk about go in a more detail about the functional impact, like talking about the walking distance, work capacity, sleep quality, mood and motivation, and social participation. What can't you do now, and what you want to be able to do? So these are some of the questions which should be on the mind, on your mind when you're dealing with this case. Now, we're going to ask a bit about, once we have built a rapport, we have asked about the functional capacity, then we'll talk a bit about the opioid effectiveness. And these are the key examiner, these are the expectations. So then we're going to talk a bit about the opiates, that how much relief do the opiates give you realistically? What is the duration of benefit? Is there any breakthrough usage or any dose escalations? So these are important, especially in the opiates, that we ask these important questions. Then we talk about the side effects, obviously we know that opiates do have side effects. So we're going to talk about whether the patient is having some constipation, sedation, brain fog, falls, reduced libido, low mood, or sleep disturbances. In the medication review, we're going to talk a bit about, because although they have already mentioned the medicine's name, it's better to just talk a bit about the medicines. Here we need to be systematic. Like, we're going to ask about the exact dose, frequency, duration of all these medicines: Plexia, Endone, OxyContin. Were there any early fill requests? Were there any lost prescriptions? Are there multiple prescribers? And also ask about the other medicines which they're using, like Panadol or NSAID, antidepressant, alcohol, benzodiazepines. So a just not go in much detail, just a brief history about the medications using. Suppose we have got the list that patient is using these medications, how frequently using, what they run off of the medicine, what are they using any other medicines, are there any other measures which are helpful in relieving the pain. So all these comes in place. Then we talk about the psychological, psychosocial history. Now, this is a golden area, and I'll just mark it with red. Must ask about the psychosocial history. In any case, all the cases, this is very important. So, we're going to ask about any anxiety or depression, any work or financial stress, how is the family support, fever, fear of pain or withdrawal. What worries you most about reducing the medicines? So that will be your key questions and very high yield, and obviously patient going to tell you about his goals. Okay. What would a good outcome look like for you in 6 months? So here we are talking about future for the patient. Suppose like planning in the next 6 months that what we should be done, and this is applicable to many cases as well. Then we have to talk about the patient concerns is important. Empathy, these are the empathy test point. So patient says, doctor, I'm afraid if I stop these, the pain will come back. I can't sleep without them. Now, obviously, we have to practice for some model responses. So here, you can say anything, but I just put something here for you as a model answer. So you can say that that's a very understandable fear. Anyone who's been on these medicines for a long time would feel the same. I want to reassure you that we won't stop anything suddenly, and you won't be doing this alone. So it's just a reassurance and just working as a team with the patient. Now, why this course? Because we are validating the emotions. It does not reinforce opioid needed, and it reduces the threat response. Then moving on in the minute 5 to 7, almost halfway, we are already halfway. So we're going to talk about, we'll do our assessment. The previous tibial fracture fully healed. There's no red flags for ongoing structural pathology. And here we're going to think about a problem list. That the problem list is the patient is on long-term opioids, and so there's always a risk of tolerance, dependence, and reduced analgesic effects. There's a fear of withdrawal and pain recurrence, and there's a functional limitations and possible mood overlay. So obviously at this point we can say aloud that at this stage the risk of ongoing opioids outweigh the benefits. Now these are the things which we really have to be more empathetic. The tone should be soft, that so that the patient doesn't feel pressured. We can always give them the options, and with the right communications, already we have built the rapport with the patient. So I think should not be that difficult, but we should suggest what is right and what is wrong in an appropriate manner. That I know that it would be difficult for you to get out, but we will help you, and I don't think so the opioids can benefit in long term. So all these things should be on your mind. And then we go to the management plan, and we must explain this clearly. Also, some of the things which you can say along the line. So opiates, they works better for short-term pain. After months to years, the body becomes used to them, so they help less and can actually make pain sensitivity worse, and something we call opioid-induced hyperalgesia. Explain the dependence versus addiction. Like dependence is expected physiological adaptation, and addiction is loss of control. harm-seeking behavior. Use always neutral language, never use addicted. Talk about the non-pharmacological strategies. Now we are in the management part. So because examiners expects you have a multimodal care. So pain management clinic, multidisciplinary approach. So referrals in the pain management clinic, physiotherapy, graded activity, strengthening, pacing, maybe refer to the psychologist, CBT for pain, fear avoidance, about the lifestyles, sleep hygiene, gentle exercises. So pain management, remember that isn't about the zero pain, it's about getting your life back. And you can tell to the patient that it will take some time, it will not be zero pain, but slowly, um, uh, we can off the opioids and patient can have the life back. Medical optimization, so here is this is a high yield as well. So when we talk about the medicines, going to talk about in detail how we're going to do the opiate tapering. Not necessarily that you should exactly know that how going to taper it and must plan, but you can just mention it that we will work together and we'll work on opiate tapering the opioids. And normally it is we reduce the total daily dose by 5 to 10% every 2 to 4 weeks, and we're going to adjust pace based on the symptoms. Ideally we should stop the short acting endone first and then simplify to long acting opioids only, then gradually we taper that. The slower we go, the more successful it usually is. Adjuvant medications, well, depending on the pain type, we can do some paracetamol, duloxetine or amitriptyline. We like to avoid the NSAID long-term use, and side effects management is also important. Like if there's a constipation, then we like to prescribe some Movicol or coloxacina. If there's nausea, maybe short-term antiemetics. Sedation, review obviously doses and CNS depressants. Then obviously safety and monitoring is also important. This is maybe not important here, but if you in a case discussion, these cases, you will always they're going to ask about the safety and monitoring. So obviously simple things like check the safe script and single prescriber in pharmacy, avoid benzodiazepine and alcohol, and false risk, cognitive effects. And sometimes if the patient is on opiate dependence, we can also offer the patient some naloxone, and if the patient is on multiple opioids. So these also can be considered, but I don't think so it will come in the clinical encounter, but it can come in the clinical discussion. So mental health support is important. So normalize the psychological distress, pain and anxiety. Often they feed into each other. Screen for depression, anxiety, and emphasize support during taper. Patient empowerment is important. Set functional goal. Important to have a written taper plan. So just mention it that we'll work it together, and I will do a plan for you, and we'll do in writing. We can do some education resources. We can ask the patient to refer to some websites like Pain Australia and Turning Point, and these are the two websites which you can mention. And then we're going to follow up plans. We're already ending the consultation. We're going to review in 2 weeks, assess the withdrawal symptoms, and you can, if you have enough time, you can say, okay, Mr. Robert, I'm going to review in 2 weeks, and we're going to discuss about any withdrawal symptoms, sleep, mood, functions, and going to adjust the tapering if needed. If things becomes too difficult, we slow down. And we're going to work together with each other. So these are the simple things which will help you. So in this scenario, the take-home message is we should demonstrate the empathy. Opioid prescribing should be safe. multimodal pain management, like I mentioned, that go for the pain management clinic and take help from the psychologist, share decision making, and patient-centered care. Hopefully, I have helped you a bit for this. So, thanks a lot, and I'll talk to you in my next video. Thank you very much.